Restriction on pulmonary function testing is one of the easiest patterns to recognize, but one of the most dangerous to oversimplify, because once you identify restriction, the next question becomes, why are the lung volumes reduced? A restrictive pattern generally means the lungs are physically unable to expand normally, leading to reduced total lung capacity and reduced forced vital capacity. But not all restriction is the same. One of the first things I look at is the diffusion capacity, or DLCO, because it can quickly help narrow the differential. If lung volumes are reduced, but the DLCO remains relatively normal, I start thinking more about extrinsic causes of restriction. Things like obesity, neuromuscular weakness, chest wall restriction, diaphragmatic dysfunction, or even suboptimal inspiratory effort during testing can reduce lung volumes without significantly damaging the lung tissue itself. An obese patient with mild restriction and a preserved DLCO may have a completely different underlying process than a patient with progressive fibrosis and a severely reduced diffusion capacity. Now, if lung volumes are reduced and the DLCO is also reduced, that raises much more concern for intrinsic parenchymal lung disease. That's where interstitial lung diseases enter the differential. Pulmonary fibrosis, autoimmune-associated ILD, hypersensitivity pneumonitis, sarcoidosis, and other infiltrative lung diseases can impair both lung expansion and gas exchange. But there's another important pattern to recognize. If the DLCO is reduced while lung volumes remain relatively preserved, that can sometimes point you toward pulmonary vascular disease rather than restriction itself. Things like pulmonary hypertension, chronic thromboembolic disease, or even early emphysema can reduce diffusion capacity before lung volumes significantly decline. And this is why pulmonary function tests should never be interpreted in isolation. You always integrate them with the patient's symptoms, smoking history, occupational exposures, imaging findings, oxygenation, and overall clinical presentation. Because the PFT itself doesn't make the diagnosis, it simply points you toward the next question you should be asking. So when you see restriction on a pulmonary function test, what's the first thing you look at? Let me know down in the comments. And if you enjoy real-world outpatient pulmonary education, make sure to like, subscribe, and follow the Pulmonary Perspective for more pulmonary and sleep medicine content.